you know we're involved in Jadis, and we have to disclose that, and we will be talking actually about Jadis, and I think everyone on the call is using Jadis, but we'll also talk about other approaches to the problem today under discussion, which is intimate partner violence, IPV. It used to be called domestic abuse, if you can remember that, but that term is identical to the more in term of IPV. And the CDC's definition, just want to be sure everyone understands that we're talking about coercive behaviors by an intimate partner, but it can include not just physical things, but also psychological abuse. It includes sexual assault and progressive social isolation. That cases in Cleveland where they locked somebody up is extreme, and deprivation and intimidation. All of that is under this general rubric called intimate partner violence. And when you spell it out that way, we find out that it's very prevalent. 1 out of 4 United States women, 1 in 3 globally, and in teens, and the peak vulnerability is between 16 and 24 years. Some of those people show up in your pediatric offices. So 1 in 5 U.S. teens come under that definition. That's kind of a lifetime. At any point in time, have they ever experienced intimate partner violence? And then if you were looking at your practice, and there was one study, it was in a suburban practice, and they found 17% of the mothers taking their kids for well child care were having intimate partner violence. It's mostly females, but also males, and also not just the heterosexual, but the LGBT population as well. So now, the reason we were talking, everyone's talking about it, and one of the reasons everybody's talking about it is that the United States Preventive Services, the USPSTF task force, has come out with a statement saying that routine screening is recommended, and that's through the childbearing age, and they define that as age 14 to 46. So they had, for a while, said there wasn't enough evidence, but in 2013 they said, yes, there's enough evidence, and that's not all. JCAHO, if you're under JCAHO in a hospital, but also the Affordable Care Act calls for it, and there are mandates from the AMA to the AAP and family medicine. Certainly OBGYN is very involved in this. And so what they're talking about often is the associated adverse health outcomes for the women, and some of those are obvious, and death is one of those. But how about for pediatricians? Because this has not been under the purview of pediatrics solidly. And so for pediatrics, we really need to think about the harmful effects on children. And the first harmful effect is to know that there is a co-occurrence of IPV and child maltreatment. And often, intimate partner violence happens before there is a report of child maltreatment. And so it's considered a precursor condition. And so if you're going to be involved in...
Everybody should mute your phone if you're not talking, okay? We got a lot of background noise. So just mute your phone if you're not talking. Thanks.
So this is a core issue if you're involved in thinking about preventing child abuse. You have to recognize the earliest precursor, and that's intimate partner violence. And then if you look at the studies, as we've learned about what effect does it have on the children, children can actually be involved and they can actually be hurt. They are collateral damage. but it has, being in an environment of intimate partner violence is well documented now. There's effect on their emotional and cognitive development. There are higher rates of impairment. There's a greater risk of being someone who uses violent coercive means to resolve conflicts. Witnessing IPV is associated with long-term mental health problems, and some of the main ones are like internalizing, anxiety, sort of like PTSD. When you're observing violence in an environment where the adults are supposed to be your source of safety and support. And so there is a lot written and out in the press about toxic stress response. And this would be when this came to light with Dr. Folletti's studies. You may have heard about the ACE outcomes from the Kaiser population, and they looked at adverse early childhood experiences, and being involved in an intimate partner violence family was certainly one of them. And the outcomes in this longitudinal study included all kinds of adverse health outcomes: suicide, depression, obesity, heart disease, liver disease, future violence, unintended pregnancies or higher rate, smoking, substance use was at a higher rate, and early death. And if you had 6 of these adverse outcomes, you died 20 years sooner. So there's a great interest now in what the mechanism might be, and interest in some indirect evidence that it could disrupt brain development, causing inflammation, and even how DNA is expressed from animal studies. So this is clearly something that is very important to pediatricians, even though we're talking about often about the parents, young parents of our patients. So one approach had been case finding. And so when you're doing the mode of case finding, you're looking for risk factors. And what are they? Individual low self-esteem, marital conflict, instability, community variables such as poverty, but it's not only poverty, all demographics and associated factors of poverty, and then societal ones where the more traditional gender roles occur. But in fact, case finding is not recommended, screening is recommended. So now we're talking about, we know that it goes across demographics. And so one approach to screening is asking parents. And so the examples of people, how to frame the questions are difficult, and some examples that people have used, mostly for adults, say, I'm concerned about my patient's health and safety, so I ask all my patients. First, to sort of disarm people that, we're just doing this to everyone. It wasn't something about you that made me think that you are involved in this kind of violence. Because violence and threats are so common in a relationship, I ask all my patients. The main thing when people talk about asking and starting the conversation that way, the sense of it is that if you express true concern, people generally are not offended, even in a variety of sensitive topics. And that's the thing to keep in mind if you're going to screen by asking questions. It so happens that asking questions or case finding doesn't work out as well in terms of identifying cases as using standard screens. And there are a variety of standard screens. They're on the slide, several of them. One called HIPS is the one that's studied the most: hurt, insult, threaten, and scream. And there are 4 items. It asks about the last year, last 12 months. They're very different in the interval they talk about. Another popular one is waste, woman abuse screening tool, and that's 8 items. There's a 2-item version. And it asks if you've ever had exposure. Then there's the partner violence screen, and that's a 3-item one. And that focuses on physical violence and safety. That one is in Chattis, and many of you are using that one. And they all have, limited sensitivity and higher specificity. And there have been a range of studies, and I won't get into it. There's another one called the Abuse Assessment Screen, and that has more sensitivity and less specificity. That's particularly good in OB. It talks about pregnancies also. The one we wanted to focus in on here is the one that we are providing in Chattis, and for some reasons I'll be discussing. This is called the SEEK, the Safe Environment for Every Kid Parent Screening Questionnaire. This is developed by Howard Dubowitz. Many of you know Howard. He's at University of Maryland and his colleagues there. There are 14 items. They cover food insecurity, parental depression, parental substance use, harsh punishment, and IPV. And the reason for that is that they all seem to go in company. They're all associated phenomena. If you're going to be asking about one thing, you probably have to ask about the other. So that team came up with a 14-item screen, and many of you may have been involved in some of his research. And there are 5 articles now, one of them cited on the slide, and showing in Maryland, primary care pediatrics in Maryland, a reduction of child maltreatment outcomes by 30% in 2 randomized controlled trials. So it's really a very interesting tool for us. He used the tool on paper and came to us to see about making it available through the computer, through Chattis. And screening is better than asking, but having a computer ask the questions is even better than doing it on paper. There's plenty of data that shows that for some reason people are willing to confess this kind of thing to a computer rather than to a person. They don't want you to think badly of them. I'm not exactly sure why, but the data is very clear. It increased rates of domestic violence discussion, disclosure, service provision. They consider it more acceptable to do computerized screening. So what's getting in the way from everyone, and pediatricians are not out there screening for IPV. The last survey I know of, there are only 5% of pediatricians who are doing it. But that was before the latest recommendations and requirements. Some of the barriers are pretty obvious. Most doctors will say, this is out of my scope of work. People have tried to say, okay, let's think about your work a little different. Think about this as like a safety program and a wellness-centered IPV program. And then obviously people don't know what to do if they get a positive result. They're uncomfortable starting the conversation. It really requires training. And do you have the resources? Where are you going to refer? And it takes extra time to have this conversation if it's going to be done during well child care where screening occurs. So when people look at what kinds of communication strategies work, and people have studied and have recorded primary care doctors talking about these issues, and one thing that's clear, even when using these screening tests, they are very good at avoiding this discussion, and they might ask leading questions, they change the topic, or they may not respond at all, and that's been well documented. What's effective is when the doctor demonstrates empathy and make empathetic statements and active listening. That's reflecting and summarizing what the parent or patient said and some encouraging remarks. The most effective approach is part of motivational interviewing. That includes empathetic statements and reflective statements, but also focusing on acknowledging the ambivalence that parents have about talking about all this stuff, and so that people are just not open to hearing about the good logical reasons why they should stop doing this stuff until they can acknowledge and think about what's getting in the way, the cons. So weighing the pros and the cons is the essence of motivational interviewing. And then there's this other kind of theory that has to do with stage of change, and it depends, are they ready to leave the household, or been thinking about this for a while, or is something they haven't thought of before, and the conversation has to change compared, provided what stage of change they're on. Now this requires time. It's easier than avoiding it or giving some quick advice, and it actually requires some training. There are certain phrases that seem to work better in research, and when people are trained, so it comes comes out of your mouth automatically, then you're going to be more effective. So what I'm going to talk about now is our approach in Chattis, what we're trying to do. And we took the Seek 14-item screen, and we decided we want to help people be able to do motivational interview, address the time factor and the training factor in the following way. First, to make this more efficient, we are using the computer to get a motivational interview started. So the Seek identifies a positive screen. That's the 14-item screen. And then there are probes for are they motivated? What are the pros and cons? And the computer is beginning that process before you walk in the room. And then the other thing that makes it more efficient is we're going to help you with documentation. And also, post-visit, we're going to leverage that opportunity through this care portal with individualized messaging. And that could be printed out in handouts. I'm going to show you that, or through the Memory Book Care portal that I hope some of you are using. So the training, our notion about training doctors now isn't lectures like this, but in the moment of care, at the moment you're seeing a parent who says that she's had intimate partner violence, and you're going to see some teleprompters that's like the president uses in giving a speech. Here's some words that might work, and try them out. And there are hints, and then there are optional support things before and after the visit, electronic chapters, video examples, and we're going to give you MOC4 credit if you want it. So I'm going to run you through an example. This is a fictitious patient, Sam Jones. His mother sees a screen in Chattis like this, introducing the Seek. And there are some questions that are sort of easier questions about safety, and this is food insecurity. The parent says, no, I don't have a problem with food insecurity. But here's the question. The last year, have you been afraid of your partner? This is a question that the Seek team boiled down. It isn't the most sensitive question in the world, but there's a very comprehensive outcome measure they use, but it is very specific. So 98.98 specificity for this question, 75% positive predictive value. So this is a good one to get started with, because it doesn't take on everything, but it's likely that the parents, if they endorse this question. So this parent endorsed that question about being afraid. And then it goes on to ask, so what's been going on? Physical fighting, yelling, threatening, how much contact you have with this person every day or most days, and how is it impacting on you? In this case, sleep. And my friends, are you getting any help? No. Do you want any help? No. And what's getting in the way? Well, I'm worried that my partner might get mad and make things worse. Is there something else getting in the way? No. And well, if things were to, if you were to get to a different readiness for change, that is, if things were to get worse, what would you be willing to do? This is the computer asking the parent before the visit. Well, I'd be willing to talk with a mental health professional and might get a restraining order. So this next slide is the Chattis results that you are all familiar with, and here's the Seek. Parents there for child's checkup, and had no idea they were going to talk about such a sensitive issue, certainly ambivalent about it. But you see that, ages and stages is okay, and everything, skin rash is not a big deal. But there's this intimate partner violence, so you hit that button, and it says PST. That's our new decision support model, patient-specific template. We're going to give you decision support related to this particular patient, not just the topic of, even in this case, intimate partner violence. I'm going to show you that. So you click, and here you are in the world of the Seek PST, and there's a red alert there on partner violence, and you see the item that was endorsed, and there are up at the top, this is what we call the teleprompter. There's a reflect suggestion. I see the questionnaire you completed. See from the questionnaire you completed before the visit, you're facing some challenges. All parents have tough times. And so this is a way to get started. Then you click on the partner violence tab, and you see some further suggested text to get this specific issue started. I see you've been having a tough time with your partner. And then on the right, I want to point out that we are creating documentation of the visit through auto text. Auto texted, all the stuff on the right came from the questionnaire, so you've got a lot of documentation done before you even get started. Now, to get to the heart of the matter, you might click on this barriers area, and you see a teleprompter that gets you right to help in addressing the parent's ambivalence. And we like to start with, what's getting in the way, the cons. I say, I see you're worried about your partner getting mad. This comes from the specific questionnaire that the parent completed. You're right, doing something about the problem has risks. It sounds, and so that then you can reflect on pros. Why would you want to do anything? It sounds like while you're in a difficult situation, doing nothing has significant risks. Yet this is important. This is an important issue because issues like this are known to be unpredictable and potentially dangerous. And it looks like it is already affecting your sleep and friends. Those are the barriers that came from the questionnaire. So what you're getting here are some phrases that come specifically from what this parent's endorsed. Any question about that? Okay. So we click here, you get a different teleprompter. You don't have to use these things, but we're trying to give you some suggested language from expert opinion. Then you might engage that parent and go right to the plan tab over here, and the partner violence part. And here's some more suggested discussion of how to address the problem. And you can see in the area of partner violence, there's a question where we are collecting information to give, and even local information to give to this parent who has this particular problem. But we don't want to give them a handout. We don't want to put it in the care portal unless they say, even though it's a confidential place, unless they agree to it. So in this particular case, in the other conditions in the PST, like depression, we don't have this condition, but we say, do you agree that is it okay to send you information in the secure section of the memory book? So we've done that, and by clicking on things or by the defaults, we're putting together some recommendations. And then there's this particular slide shows additional hints. If you hit one of these buttons, recommendation buttons, if you didn't know what an emergency plan is, this tells you what an emergency plan is. You don't have to do this. There are plenty of little hint things, but all these things are optional, of course. So we're ready to confirm the handouts. Handout is in quotes because we're talking about stuff that's going to go right to their care portal, or you could print it. And so it says, are you ready to confirm the handouts and confirm the resources that have been selected? And there's a safety plan here, and then another handout. And then when you click on this care portal area, these are notes that have come, and you can see that it even has your name here, so you want to pay attention. Dr. Ray Sterner wants you to be sure you know how you can talk to someone by phone and can help, get help for partner difficulties and stay safe. And then they can click on escape plan. They can click now. When people are going to use this PSP, we are going to ask you first about local resources you prefer, and we're going to link them to your office by zip code if you want to use this system. So if you've done that, then they click on local resources, and there will be some, maybe your favorite social worker will be there. Maybe it'll be a shelter there. So that's the paragraphs, and you can actually write in some more text if you desire, but we're ready to look it over, and you can click and you can print the handout, and you can see that those paragraphs are there that can be printed, and there's a handout about domestic violence below here. And then we're ready to lock the report and decide and make a conscious effort to send this to Sarah Jones, the mom, because she said she wants to take a look at it and what we have to offer. So then mom goes to her care portal and sees that, there's visit notes from that last visit and resources. Here they are. And these are the headlines. They can click in to see the paragraphs that I showed you a moment ago. And they can click into these resources and get a safety plan and that handout. Just wanted to say that when you lock, you have all this documentation that you could print and put in your chart, or copy paste, or if you have an EMR that's integrated with Chattis, it'll go there. So if this has stimulated you, piqued your curiosity, you may want to, this may be a moment you want to read more about intimate partner violence, this electronic chapter. There are videos. You click here and you get into a video. This is some screenshots from a video discussing the effect of viewing violence on kids. And there are scenarios, case examples. There is a patient and a doctor talking and giving you some ideas. This is a e-chapter, and then I wanted to just throw this run chart in. If any of you who've done a MOC4 for us know that we're going to produce these kind of charts, and if you do intimate partner violence with SEEK, we can give you MOC4 credits, and we'll show you a chart of the number. In this case, it's the number of SEEK screens that were done, and this was a depression. This has to do with the number of interviews that were documented when the screen was positive. So that's it.
So Emily, I know that you've been working hard in the continuity clinic with the residents, and I believe that this is an area that you've been encouraging too. Can you talk a little bit about that?
Sure. So we have mandatory screening for moms of all babies 0 to 6 months, although it often goes on beyond that. And we have a maternal mental health, maternal and infant case manager who can meet with any of the moms that screen positive. When we've looked at issues of intimate partner violence and postpartum depression, because we're looking at the first 6 months of life, the comorbidity there is very high. We get about, and so the screening we use is a couple of questions from the Edinburgh survey of depression, and then we ask some questions about safety in the home, as well as a bunch of other questions like WIC and car seats and things like that. we get about a 25% positive rate on the endorsing postpartum depression and about a 10% endorsement of intimate partner violence. Although, interestingly, of the moms who endorse intimate partner violence on that paper screen, over half of them have postpartum depression as well. So there is a lot of comorbidity, at least in our patient population at the Harriet Lane Clinic for that. One of the there's something, I don't know if you guys know the RADAR screen or the RADAR kind of acronym, which is, now I'm not going to be able to remember what it is. Let me see if I can pull it up off my file. But there are, here, it's the R stands for routinely screen mothers for abuse. The A is are you being hurt? And we actually try to ask very specifically, hit, kick, punch, intimidated, frightened, anything like that, because if you ask more specific questions, you're more likely to get an answer. And then there's some questions to follow up as, these are things that where your screening tool addresses. But then we also really highlight how to document the findings, because I think that could be complicated if both parents have access to the chart or things like that. So we talked a bit about that. I'm thinking that then the A, so D is document, A is assess safety of mother and children, and R is respond, review options, and then refer as needed. And it's just sort of a helpful acronym to keep people thinking about what to do. The other thing that I think is a big issue for these moms is a sense of isolation, particularly in the patient population that we take care of where there are already so many other psychosocial burdens, and the financial challenges can be very particularly difficult to have these moms work around and things like that. So I think that it is, intimately, as Ray mentioned, intimately tied to child health and well-being, both in terms of number of ER visits as well as a longer-term outcome and risk for mood and anxiety kinds of issues and just overall health. A child can only be as healthy and safe as their parent is. And so I think it really is absolutely critical. And you all are the only people that have access to kids and families. So I think it's such an important topic. And, it's really probably nothing more important, really.
When I was showing those slides, I skipped over the questions from the SEEK. We would administer the whole SEEK, which has the parental depression, the two PHQ-2, and the substance use question, food insecurity, and harsh punishment question also, because they all seem to go together. So you'll get, and then you may have multiple things that are positive, and you've got a well-child visit. You have to decide which one you want to really talk about. You probably can't talk about more than one, and negotiate that with the parents.
Yeah. But I would say, though, that safety trumps everything else, because nothing else can be addressed if there's an unsafe issue.
Emily, can you comment a little bit about sort of the new move towards trauma-informed care and what the different parts of that expression, like what does that actually mean for pediatricians to do trauma-informed care?
I think probably the word means different things each time people use it, and it's sort of become one of those buzzwords. But I think the way I try to think about that concept is it's kind of like a prompt to remember that people have lives, and in their lives, good things happen and some very bad things happen. And being aware of what some of those bad things are and how they have been interpreted and understood in a person's narrative of their life. For a lot of you all, it will be the parent, but also some of the youngsters as well. The meaning that those events have for the person, if we are not sensitive to that, our delivery of care, even around routine things, may fall flat or it may be harmful because we've missed something that's important to the patient. And I think that being sensitive to triggers, reminders, things that can, in their routine daily life, can make living harder is part of our responsibility to be sensitive about. So trauma-focused cognitive behavioral therapy takes a slightly different approach to work around a trauma narrative. And I think even just the idea that there is a trauma narrative, or for some of our families, we need to help them construct a more adaptive and positive frame for their trauma story, can be a very important thing. So I think I'd have to look up and see what the original meaning of the word was, or the phrase was supposed to be. But I try to think of it as, what do I need to remember when I'm going to work with any person around any kind of needs? And, sometimes it can be referred to, we don't want to do seclusion and restraint because that can be a trigger for families. But it's really about how to think about what an individual person needs to heal and be successful as they go forward, given what's happened in their past. Mm-hmm. All have an autobiography that we have in our heads, that we tell our story of how we got to be who we are, and how the different influences, good and bad, have impacted us and our choices and our options and all of that. And sometimes the way people incorporate a traumatic event into their life doesn't necessarily help them be more functional and more adaptive and more successful, but instead it can either be compartmentalized so that they have a very fragmented way of thinking of themselves, or it becomes so defining that it's, I'm the victim, or other kinds of nothing ever works out, and it can be a very negative self-view and worldview. And so there are ways to, and also the other thing that can happen in a family is that each person individually has their own story, but sometimes we need to help a family share their stories and come to a family story that they can all feel okay with. And so there are issues around safety and trustworthiness, and transparency, and empowerment that all become part of a trauma-informed approach to caring for a person.
And it may sound like that's something that only a psychiatrist can do, but I actually think yeah. I think this is really something everybody can do. And some of it's in the way we as pediatricians talk about it and say, you got into a tough relationship and you got out. And that's a huge accomplishment on your part, to protect your kids by getting out of that situation, or to work on the relationship so that you were being clear that you would not put up with that. And it's really you can reframe it in an empowering way. So that's a good thing.
Mm-hmm. And I think even just remembering that, even if we can't go that extra step of reframing, but even just remembering that some of our patients have had really horrible things happen, and just that awareness will impact how we ask questions, how we respond to answers. And I think that's an important frame shift for us to have as the clinicians.
Mm-hmm. Absolutely. Now, in terms of resources, Ray, do you want to talk a little bit about what, besides the escape plan, which I think you described really well, do you want to talk a little bit about what kinds of resources it would be good for people to know about near where they live, to make sure that they, and of course we can add them to Chattis, but the main thing is for them to be aware of them. I know at Hopkins they have sort of a list of sort of the basic survival things, like where's the WIC program and what's the RAPE hotline and so forth, but do you have a suggested list of things that people should sort of be prepared with? One of the things about the task force, the mental health task force, was the very first paper that came out of the American Academy of Pediatrics mental health task force said, first, prepare your office so that you are ready for stuff like this to show up, because if you haven't been asking before, you may not sort of know what to ask next. And it's good to have a few of those things sort of lined up in advance.
Yeah. I think the first thing is if anyone, if you're unable to complete, you plant the seed, maybe it doesn't even happen. But if you have a social worker that you trust and can continue a conversation, I think that's the number one resource if there's nothing else. Now, if you are getting further into a conversation and you know about the House of Ruth and the shelters and hotlines, those are things that we're going to provide through Chattis. When you're in Waldorf, the House of Ruth is too far. Maybe there isn't anything there, but we need to find out and at least find out someone who knows. If you don't know all these details, but there are national hotlines, and those we can make available to everyone.